Hola, ¿qué tal? Listo. Qué gusto estar con ustedes en esta última actividad del año del Colegio Mexicano de Pediatras Especialistas en Inmunología Clínica y Alergia. Este Summit de Alergia a Medicamentos, que será en 3 días, del 14 al 16 de diciembre. Y quiero comentarles, hubo algunos cambios en las sesiones, hubo algunos médicos que no pudimos contactar, sobre todo una nada más, que tuviera un problema con COVID. Otra doctora, la doctora Cernas, estuvo infectada con COVID y de todos modos pudo grabarnos la plática. Las pláticas están grabadas, así que si tienen alguna duda, mándenoslas por el chat y nosotros se las hacemos llegar a los doctores. El problema era el tiempo para poderlos coordinar y que estuvieran ellos ahorita. La mayoría de ellos son europeos y tendrían que estar a medianoche contestando preguntas. Entonces, bienvenidos todos a este Summit. Y es para mí un gusto y un placer poder presentar a Francisco Espinosa, el presidente actual de la mesa directiva y un gran amigo, y agradecerle sobre todo su confianza y el haberse adaptado a esta nueva modalidad que lo hizo excelente. Gracias, Francisco, por haber hecho 2 años académicos muy buenos, y la verdad es que creo que tomaste al toro por los cuernos de una muy buena manera y esto llegó para quedarse. Entonces, otra cosa antes de que empiece Francisco también, en la parte de abajo en donde está interpretación, todas las pláticas están con interpretación simultánea en español, entonces nada más es cuestión de que toquen el icono de interpretación. De todos modos, en el chat les mandaron la manera de cómo hacerlo, y también va a estar simultáneo si lo están viendo por YouTube o por alguna otra línea. Francisco, te dejo la palabra y muchísimas gracias.
Muchas gracias, Benjamín, y muchas gracias a todos por estar aquí con nosotros. Y gracias a Benjamín por la organización de esta última actividad académica. Quiero presentarles nuestra primera plática, el doctor Werner J. Pichler. El doctor Pichler es médico internista, especialista en inmunología clínica. Él tuvo un entrenamiento en los Institutos Nacionales de Salud y luego estuvo como adscrito y luego como jefe de la División de Inmunología Clínica y Alergia en el Hospital Universitario de la Universidad de Berna, en Suiza. Tiene más de 400 contribuciones en la literatura. Y algo importante es que a partir de 2014 dejó de trabajar en la universidad y ahora tiene una empresa de asesoría y consultoría en el análisis y en el diagnóstico de reacciones adversas a medicamentos, y es de las gentes que más conocen de este tema. Él nos va a hablar sobre estas etapas iniciales de cómo diagnosticar al paciente que tiene alergias a medicamentos. Y le agradecemos muchísimo su contribución.
Hello, my name is Werner Pichler. I will speak today about drug hypersensitivity reactions, basic concepts and classification. I don't have to declare any interests, conflicts. The content of my presentation will be divided in different parts. First, I will discuss the definition of drug hypersensitivity and the role of non-covalent versus non-covalent drug-protein interactions. I will describe the distinction between contact dermatitis and systemic drug hypersensitivity reactions and the role of covalent versus non-covalent bindings in these reactions. Then I will describe some examples of non-covalent drug protein bindings which result into drug hypersensitivity reactions. I will discuss briefly the fake antigen concept, the destruction of blood cells by enhanced affinity models of anti-erythrocyte and anti-thrombocyte antibodies, and I will discuss the PI concept. At the end, I will show the impact of this new approach on understanding the history, clinic diagnosis, and risk assessment of drug hypersensitivity. Drug hypersensitivity reactions are immune-mediated reactions towards a small molecular protein, a drug, which elicits an inflammatory response. Symptoms range from mild to severe and include rash, anaphylaxis, serum sickness, Stevens-Johnson, stress, and so on. Actually, when you ever have seen a patient with acute anaphylaxis or Stevens-Johnson syndrome, as shown here, then you ask yourself, what is the purpose of such a reaction? One instinctively questions the biological benefit of such a fulminant and catastrophic immune reaction. And therefore, the question arises whether these severe drug hypersensitivity reactions are excessive variants of a regular immune reactions to an antigen, or are they the result of a qualitatively different immune reaction? In other words, drug hypersensitivity, is it a normal immune reaction to an antigen, immunity and tolerance, or is it the consequence of an unorthodox immune stimulation resulting in an abnormal clinic? And as you may know, I favor the second version. Let's discuss it. And first start with drug interaction with proteins. And you know that drugs always bind to proteins constantly, and they bind some to albumin, to transferrin, to immune globulins, and this happens very quick. It's by non-covalent bindings. It's reversible, label, and it doesn't interfere with the immune system. It's not an antigen. It's ignored by the immune system. These non-covalent bindings are fast, not very stable, sometimes a little bit more, sometimes less. They are reversible, and they rely on different molecular interactions. Actually, such interactions are the basic for many of pharmacological activities of drugs, and one speaks on target or off-target reactions, whether it binds to the intended target or is a non-intended target. And you have to know such non-covalent bindings precedes any covalent binding which may take place at the same site. So in the beginning, you have non-covalent binding as shown here. And afterwards, and after a while, it's a slow step, you can have covalent binding. For example, here with the amoxicillin structure, when it's opening the beta-lactam ring, and you may bind to the lysine groups in the presenting in the peptide region which you attack. And then when you have a covalent binding, you speak of an antigen because it's a very stable complex, actually changed the protein completely. You have a new antigen. This part is not a new antigen. Now, all hypotheses of drug hypersensitivity have been based on this antigen formation concept by covalent bonds. Some drugs actually are able to do so, sometimes after metabolism, sometimes directly, and they are so-called haptens. They share the electron pairs with proteins, and you form stable covalent bonds. It may bind to different proteins. It results in immunity. It's a regular, controlled immune response. B and T cells are involved. And actually, the surprising finding is that this normally doesn't cause symptoms. When you take an amoxicillin tablet, 1,000 milligram, you haptenize your body. But the immune response against this amoxicillin is very rare, and you normally don't make a reaction. There's one big exception, the contact dermatitis. In contact dermatitis, the antigen is indeed a hapten, and this hapten is often also somehow toxic, so it provides also some co-stimulation. So, and this is a localized cell homing to the site where antigen penetration causes danger, and therefore you have a covalent interaction and a localized inflammation. it is not equal to systemic drug hypersensitivity. Like an example here to the right, where you have a systemic reaction, you don't have special homing to some sites, and actually, when you investigate these patients, you find non-covalent bindings at the most. The drugs are all over, but not by covalent bonds. Now, these non-covalent bindings are based basically on electrostatic interactions, P effects, van der Waals forces, and hydrophobic effects. And this non-covalent binding can bind together and form quite a stable interaction. Per se, a single bond is mostly not very stable, but altogether it might be almost as stable as a covalent bond. It can bind to albumin, to transferrin. It can also directly interact with immune receptors. It can bind to T-cell receptors, to HLA, or to the antibody binding site of IgG or IgE. And then, in these cases, it may cause drug hypersensitivity, which is, in this case, as it is not a non-covalent binding, a non-regulated, unusual immune stimulation. Sometimes it affects B cells, sometimes it affects T cells. In T cells, it can even initiate an immune response. In B cells, normally you have first a normal immune response to a hapten, and later you can have elicitation phase elicited by non-covalent binding, not by a hapten. So you need two things, a rather affine binding and immune receptors which are targeted. So the immune reaction starts with drug binding to proteins. You have to ask yourself how and where. Is it covalent or non-covalent, and where? Is it an immune receptor or not? If it's covalent, you may form an antigen, and then you have can make an immune reaction, like in contact dermatitis, if you have co-stimulation. If it binds non-covalently, then you don't have any antigen. It's ignored by the immune system with certain exceptions. And these exceptions lead to drug hypersensitivity. Which drug hypersensitivity reactions appear after non-covalent drug binding? How can one incorporate the type of drug protein binding in a clinically useful classification of drug hypersensitivity? And what does the non-covalent binding concept mean for understanding history, diagnosis, risk assessment of drug hypersensitivity? Here, there are three models of drug hypersensitivity reactions based on different non-covalent bindings. The fake antigen model, there the antigen is, for example, amoxicillin is able to bind by covalent and non-covalent bonds to a protein, for example, albumin. For the initiation, you need a covalent binding, you need antigen formation. But for the elicitation phase, you don't need covalent binding. You may have mast cell degranulation and anaphylaxis to the so-called fake antigens, which I will discuss in detail. Then you have the enhanced affinity model. You have pre-existing antibodies against rhesus factors or glycoproteins of thrombocytes. These IgG are not very affine, but when you take certain drugs, the affinity of these antibodies is enhanced, and you may have binding of the antibodies and destruction of the erythrocytes or thrombocytes, and therefore you have a blood cell dyscrasia. And then you have the PI concept. There, the drug binds directly to the immune receptors involved in T-cell activation, be it T-cell receptors, HLA, and then you make an allo-like immune stimulation with CD4 and CD8 cells, and depending on what you stimulate most, you get maculopapular drug reactions, stress, Stevens-Johnson, and tissue damage. Now let's briefly discuss the fake antigen model. And for that, you have to understand what is happening with IgE formation against the drug. and you just imagine you are not sensitized. You take amoxicillin for a while, for 7 days, for 10 days, and at the end of the 10 days, you are sensitized because it happens that you make IgE reactions to amoxicillin. But at 10 days, you have the drug, you have IgE, but you don't have any degranulation. Only when you make an intermission and then give the drug new after, let's say, 1 year, then you can make suddenly an anaphylactic reaction and degranulation due to drug-specific IgE. Here, the mast cells are reacting. Here, the mast cells are also sensitized, but not reacting. Why is this? There is the concept of mast cell unresponsiveness to sensitizing an allergen, which is a very important concept and not very much discussed, but obviously it is very clear. You know it from the desensitization of drug hypersensitivity reactions. But let's start first with the sensitization. You have a mast cell and slowly you sensitize with IgE. So you have a low amount of IgE and a high antigen because you start with a normal dose of, for example, amoxicillin. But you don't react yet. You slowly increase the IgE because you sensitize more and more, and you get more and more IgE and more sensitization on mast cells. And at the end, you have a high sensitization of mast cells, high level of IgE, but still you do not react. Simultaneously, you are getting desensitized. In initial sensitization by an allergen, you get a gradual increase of IgE and you desensitize. You make a mast cell unresponsiveness by antigen immune complexes. The same happens with desensitization. Here in this case, you start with a high amount of IgE, you are sensitized, and you give very low amount of the drug to start the desensitization. After a while, you have more amount of the drug, and at the end, you have again high IgE and high antigen, and you make a gradual increase of antigen and desensitize simultaneously. So you desensitize by an increasing slow increase of antigen IgE immune complexes. In this case, the true antigen, it's covalent binding. If amoxicillin binds by covalent means, and it's slowly formed, able to cross-link IgE, but does not degranulate due to mast cell unresponsiveness induced by slow increase of allergen. Sensitized but not allergic. It's a normal immune response to IgE, mediated by IgE. You have no symptoms most of the time. In fake antigen model now, the same drug binds first by non-covalent, it's reversible, but plus minus stable. And you have formed a new drug protein complex. It is imitating the true allergen. And it's rapidly formed, excessive, and able to cross-link IgE as well. But as it happened in excessive amount and very rapidly, you overcome mast unresponsiveness and you make a degranulation. You get anaphylaxis. Here again, covalent hapten protein induce immune response to the drug by processing, stimulation of B cell and T cells, IgE production, sensitization, and simultaneously desensitization of the mast cell responsiveness. And if we now make a fake antigen reaction, the same allergen and albumin, for example, which are rapidly formed by non-covalent means, are cross-linking IgE and make a reaction. It happens within minutes and very fast. Another possibility, which is not much discussed by the allergologists, but which are very well known before hematologists, are blood cell dyscrasias due to drugs. For example, in drug-dependent immune thrombocytopenia or hemolytic anemia, certain drugs like quinidine, ceftriaxone, piperacillin, etc., bind to CDR regions of pre-existing antibodies, which bind surface structures on thrombocytes or erythrocytes. Here, drug-dependent antibody, and here's the structure. And now you have the drug which binds somehow to this antibody, CDR region of the antibody, the complementarity determining region. And in this binding increases the affinity of the antibody for the targeted structure. And suddenly a lower affinity antibody becomes to a higher affinity antibody, and this higher affinity antibody then suddenly is destructive. It destroys the erythrocytes or the thrombocytes. And it's the main cause of drug-induced thrombocytopenia or hemolytic anemia, mostly by non-covalent binding to these regions. And just to recapitulate, in the fake antigen model, you have imitate the drug-specific IgE was was generated against the covalently bound drug as a hapten, and the fake antigen formation imitates the true antigen, is able to cross-link IgE and make a fulminant mast cell degranulation. In the enhanced affinity model, anti-blood cell antibodies, which are pre-existing, natural, often not harmful, become suddenly to quite potent antibodies which destroy blood cells. The next part is the PI concept. It is called pharmacological interaction with immune receptors. And this is nothing else than an off-target activity on immune receptors, which is, however, quite peculiar. It can initiate a complete T-cell restricted immune reaction, which has similarities to direct allostimulation. And you know, many of the drug hypersensitivity reactions are very similar to allo or bone marrow induced graft-versus-host reactions. It is clearly more than a normal off-target activity as known from pharmacology, because the reactive part in this immune stimulation are always T cells, even if the drug is not binding to T cells. And it has quite a lot of late consequences in the absence of drug, like viral reactivations and autoimmunity. Let's briefly discuss this concept of pharmacological interaction with immune receptors. You have the drug symbolized here by these balls here. The blue ones bind to relevant sites, and the binding can be quite affine, and if it is high affine to certain regions, it may cause a reaction. Most of the time it binds somewhere here or here and is not doing anything. But it depends on the affinity of the drug binding to the HLA and the T cell proteins. The localization is important. It binds here, for example, CDR3, then it can induce an allosteric effect. That means binding of sulfamethoxazole to the CDR2 region changes the structure of this T cell receptor. Here's a T cell receptor, here's a HLA molecule, and it binds with a 7-fold higher affinity to this immune complex consisting of HLA and the peptide. And you can bind to the CDR3 region of T cell receptor. And here, quite interestingly, it is typical pharmacology. The orientation, how the drug is binding to the receptor, is important. If it's binding, if sulfamethoxazole is binding to this receptor in such a way that the amino site is interacting with the peptide region here in the HLA peptide region, then you have stimulation. If it is vice versa, then you don't have stimulation. And you have, of course, also possibilities that the drug binds to the HLA molecule. It can bind below the peptide, so you can change even the peptide when it's binding inside the cell. And also important is the fact that the T cell reaction to this modification of HLA or T cell receptor itself is influenced by the degree of T cell activation. So when you have many activated T cells, for example, in viral infections, then you react easier, and when you don't have this general T cell activation. It results in a polyclonal stimulation, sometimes in oligoclonal or monoclonal stimulation when it's binding directly to T cell receptor. It is go along with strong cytotoxicity, as it is typical for graft-versus-host reactions or allostimulations. And it's very unusual when you look to this T cell stimulation by drugs. There is no strict HLA restriction, high alloreactivity of the stimulated T cells. You stimulate T cells with CD4 phenotype, which react with class 1, and CD8 phenotype, which react with class 2. You can exchange the peptide. It's polyspecific. Altogether, it's allo-like or actually super antigen-like. And when we looked, when I just showed you, it is actually a modification of the crucial part of T cell receptor and HLA, and indeed has some similarity to super antigen allo-like reactions. The PI stimulation results in many activated T cells in the acute phase, and when you mainly activate CD4 cells, then you may get stress. When you stimulate more CD8 cells, then you get Stevens-Johnson syndrome or toxic epidermal necrolysis. The puzzling finding is that many of these people who have a strong drug hypersensitivity reaction, especially after stress, make late complications. It's known that after 4 to 6 or 8 weeks, you get viral reactivations, mainly of the herpes virus group. And that this is explainable by the fact that this PI stimulation is a very potent stimulation. It's like an allostimulation. And you activate many, many different T cells with specificity for example, for your herpes viruses which you harbor in your body, and about 10% of your CD8 cells are directed against herpes viruses in your body, and that means you activate them, and the activated CD8 cells attack the herpes virus harboring T cells, lyse them, and you have a release of many herpes viruses in the circulation and in the tissue. And this goes along with viral reactivation, quite often without severe symptoms, because it's not activation of the viruses, it's just releasing the viruses, basically. And the second part is that many of the CD4 and CD8 cells which you activate in the PI may also react with self-peptides, and then you may attack your self for example, in endocrine organs, and you may have destruction of isolane or thyrothyroxine producing cells, and then you get diabetes mellitus and thyroiditis and so on. But this is rarer and happens later. Here it needs 4 to 8 weeks. Here it happens between 6 and 8 weeks after the stress activation. How can you classify now these these drug hypersensitivity reactions? I favor the classification of drug hypersensitivity, meaning you define the reactivity if it is due to an antigen, like this, for example, in contact dermatitis, that is clearly allergy. You have a new antigen. Then you have drugs which bind by non-covalent means to immune receptors. This is called PI. And then you have many drugs which bind to effector cells of inflammatory cells or of inflammation, and may make pseudo-allergic reaction like urticaria or asthma or bronchospasm and so on. Here in allergy, formation of a new antigen, Gallen-Coombs 1 to 4, or tolerance. Most of the time you make tolerance, be aware of that. PI drugs bind directly to immune receptors and elicit an allo-like T-cell stimulation as discussed, and pseudoallergy drugs bind directly to receptors or enzymes of effector cells. And it's not real allergy because there's no involvement of specific immune system. Here, when you make allergy, you make IgE, actually you make tolerance, but the tolerance is broken by forming non-covalent fake antigen. Or you have IgG, which are tolerized or not affine enough, and then you have non-covalent binding, which make it to a higher affine interactions, and then you have blood cell dyscrasias. Here, of course, in PI, you have allo-like T-cell activation, and here's different forms of pseudoallergic, which I don't discuss in detail. What is the impact of non-covalent drug protein binding as cause for drug hypersensitivity? Actually, it is enormous because it's completely different from what you learned. But on one hand, it may help you to understand the perplexing nature of drug hypersensitivity reactions. Just think of the patients you have seen with Stevens-Johnson syndrome and ask yourself, what in the hell is going on? It may help you that you realize that this is an unnatural and really a mistake also by the immune system to react. Then history. If the immune system stimulation is not due to an antigen, no sensitization is needed. And in PI or enhanced affinity model, you don't have previously exposure. And it's not require sensitization. In the fake antigen model, however, prior exposure to the drug as hapten may be required. It's not always the case, but often. With regard to diagnosis, what we detect in skin tests and basophil activation tests is due to non-covalent label binding. We do rarely detect covalent binding. The booster reactions, no boost by fake antigen and enhanced affinity reactions, but by PI, because PI is really also initiating and it may have boosting effect. But fake antigen or drugs which interfere with the affinity and are not boosting the reaction. And with regard to risk assessment, of course, you have to start from scratch again. It needs to be changed and adapted if what I tell you is true. In summary, drugs bind to proteins mostly by non-covalent means. Some of the binding is quite affine. Some of the binding may be directed to crucial part of immune receptors, HLA, T-cell receptor, or the variable region of these antibodies. And drug hypersensitivity is unusual. They appear if the drug binds with sufficient affinity to proteins and thereby imitates a true antigen, fake antigen model, and the symptom of anaphylaxis, or the drug binds with sufficient affinity to immune receptors. It can enhance the affinity of immune globulin or T-cell receptors for the antigen HLA peptide. It can elicit an allo-like stimulation, or and can also be made responsible for late complication, as the PI-activated T cells react with viral and self-peptides. So I think that this explains most of the drug hypersensitivity reactions what we see in clinic. And in conclusion, I believe a clue to comprehend systemic drug hypersensitivity is just to link the unusual clinical presentation to the unorthodox immune stimulations. Unusual clinical presentation, which mentioned Stevens-Johnson's anaphylaxis, and this unorthodox immune stimulation is not an antigen-driven immune stimulation, it's just binding of drugs to certain receptors. A substantial part, if not the majority of drug hypersensitivity reactions occur when drugs interact and affect immune receptors. And by this interaction takes place by non-covalent bindings. And I believe we need to incorporate these new concepts in our approach to patients with drug hypersensitivity and its prevention. Thank you very much. I provided you with a lot of information, but you have the chance to read it up because most of the things which I discussed with you are already published, and just recently in this year I have published 2 papers on anaphylaxis to drugs, overcoming muscle unresponsiveness, and the important role of non-covalent binding. Also, both are appearing in allergy. Thank you very much.
¿Me dejas prender mi cámara, Alfonso? Muchas gracias, y como ya había dicho el doctor Benjamín Cepeda, todas sus preguntas podrán ser hechas por escrito y los organizadores, el doctor Cepeda, la doctora Estrada Reyes, podrán mandar las preguntas a nuestros profesores y asimismo las respuestas que obtengamos. Ahora, en segundo término, les quiero presentar a la doctora Mariana Castells. Ella nos va a hablar de hipersensibilidad a medicamentos en niños. Ella es médico experta en alergia a medicamentos y es directora del Centro de Sensibilización e Hipersensibilidad a Medicamentos en Boston, en el Brigham and Women and Dana-Farber Cancer Institute. Es directora del Centro de Mastocitosis del mismo hospital y es profesora de la Facultad de Medicina de Harvard, también en Boston, con más de 200 publicaciones y más de 30 años de experiencia en la alergia e inmunología. Ella, como les digo, nos hablará de alergia a medicamentos en niños. Y también estamos muy agradecidos por su participación.
Buenas tardes, soy la doctora Castells y es un placer presentar hoy en el Summit Alergia a Medicamentos. Voy a presentar hipersensibilidad a medicamentos en niños. Yo trabajo en el hospital Brigham and Women's aquí en Boston y dirijo el Centro de Hipersensibilidad a Drogas y de Sensibilización, también el Centro de Mastocitosis, y soy catedrática de Medicina en la Universidad de Harvard. Aquí tenemos un poquito la descripción de a lo que yo me dedico, como hemos dicho antes, y es un placer para mí poder contarles un poco lo que en definitiva hacemos en el Centro de Desensibilizaciones. Mis conflictos están reflejados aquí. Entonces, la hipersensibilidad a drogas en niños la describiremos un poco con unas guías que tenemos aquí expuestas en cuanto a los grandes temas. Tenemos que los niños en principio son más están más expuestos a hacer exantemas benignos que están asociados a infecciones virales y en los cuales los niños están tratados con beta-lactámicos. De ello se deriva que se genera un etiquetado a alergia a antibióticos beta-lactámicos. Entonces tenemos poblaciones de alto riesgo, poblaciones como las poblaciones de niños con fibrosis quística que están muy expuestos a beta-lactámicos, los niños que están mucho en el quirófano también con espina bífida. Estas son poblaciones de niños que estarán expuestos más a antibióticos, más a medicinas que los pueden sensibilizar y en los cuales tendremos una alta incidencia de alergias e intolerancias a medicamentos. Por otra parte, una población que no conocíamos hasta ahora, pero que está creciendo, es las reacciones a quimioterapia en los niños. Los niños tienen cáncer, los niños tienen que ser tratados con quimioterapia y estamos ahora reconociendo, y veremos en mis diapositivas, que la quimioterapia son agentes que pueden ser sensibilizantes en niños y que pueden inducir reacciones tan severas como la anafilaxia y de las cuales se conoce poco el tratamiento que voy a exponer un poco aquí. Por otra parte, también los monoclonales empiezan a ser también parte del armamento con el cual tratamos a los niños. Y esto tenemos que reconocer también, es importante porque los niños pueden reaccionar después de muchas exposiciones a los anticuerpos monoclonales. Entonces tenemos aquí una revisión que he cogido de Seúl, de Corea, en la cual nosotros tenemos una sospecha de una reacción de hipersensibilidad en niño, ya sea por un rash, ya sea por una hipotensión, ya sea por unas manifestaciones sistémicas. Tenemos que hacer una historia detallada, como veremos un poco más adelante, describir lo que es el fenotipo que vemos, intentar llegar al endotipo a través de lo que tenemos aquí, que serían, digamos, las herramientas para saber de qué se trata, una prueba cutánea, unos test in vivo, una prueba de provocación y entonces confirmar o no confirmar la alergia. Como vamos a ver más adelante, el que un niño tenga una alergia, un etiquetado de alergia a la penicilina no le ayuda. No le ayuda como adulto, no le ayuda como adolescente, no le ayuda porque le impide que tenga... que se le trate con medicinas de primera línea, con antibióticos de primera línea, por un lado, que se usen otros antibióticos que sean más caros, con más complejidad y efectos secundarios, y por otro lado, que llegue a la edad adulta con ese etiquetado que no se ha comprobado. Entonces, tenemos aquí también cuáles son las manifestaciones clínicas en niños que sean más frecuentes. Tenemos aquí que las manifestaciones dermatológicas son las primordiales, que los exantemas maculopapulares, está también el prurito, está también los eritemas, el angioedema. Cada una de esas manifestaciones tienen medicaciones que son, digamos, más... que producen más con frecuencia, por ejemplo, los exantemas maculopapulares, están los beta-lactámicos, también pueden hacer vacunas, también pueden ser los antiinflamatorios no esteroideos. El angioedema, por ejemplo, es mucho más típico de los antiinflamatorios no esteroideos, y tenemos también, por ejemplo, las reacciones fijas, de exantemas fijos, que las sulfonamidas y los antiinflamatorios no esteroideos son los que más lo producen. Tenemos reacciones ya más complejas, como son las reacciones más severas asociadas con manifestaciones de la piel, que llamamos SCARS. Tenemos el DRESS, el Steven Johnson, la epidermolisis tóxica, el EGEP, y por último tenemos la anafilaxia, que también los beta-lactámicos, los antiinflamatorios no esteroideos. Pero vemos aquí que en esta revisión, que es del año 2020, no se añade ya la quimioterapia y los monoclonales, cuáles son medicinas que realmente los niños se pueden sensibilizar. Y tenemos aquí que cuál sería la frecuencia de la presentación de las alergias a medicación, a drogas en niños, es mucho más alta en, como vemos aquí en todos los estudios que se han expuesto aquí, la epidemiología es mucho más alta en pacientes hospitalizados, que puede llegar a ser un 10%, que en pacientes que no están hospitalizados. Eso se ve también a que, como decimos, hay poblaciones de pacientes que necesitan más hospitalizaciones, más exposición a medicación, y por esa razón también tienen más frecuencia de reacciones a antibióticos, a antiepilépticos, a inflamatorios no esteroideos, pero, como decimos, a quimioterapia y a monoclonales tenemos que añadirlos también. Entonces tenemos una frecuencia que es teóricamente menor a la de los adultos, pero que también es importante. Tenemos aquí un ejemplo de lo que decía anteriormente. Tenemos aquí una niña de 3 meses brasileña que pesa casi 3 kilos, y a los 3 meses de nacer se le detecta una lesión en el fondo de ojo que se diagnostica de retinoblastoma y necesita recibir a través de arteria retinal, aquí vemos cómo, quimioterapia. Se le da melphalan, pero luego se añade tepotican y carboplatino. Entonces, esa niña ya es una niña que está expuesta a quimioterapia de forma intensiva. A los 11 meses se le hace el tercer ciclo de quimioterapia que recibe con carboplatino, presentando una reacción de grado 3 con edema palpebral, angioedema, hipotensión, bradicardia, y que se diagnostica de anafilaxia. Entonces vemos aquí que se la tiene que tratar con epinefrina, la paciente, digamos, tiene un riesgo vital importante y a los 15 meses se la intenta premedicar con más antihistamínicos, con más corticosteroides y de la misma manera, al recibir el carboplatino, presenta una reacción de grado 3. Entonces tenemos aquí una anafilaxia en una niña pequeña que necesita este tratamiento de quimioterapia como a primera línea y recibe tratamiento apropiado, pero ¿cómo enfocamos nosotros esto? Entonces tenemos, como decíamos anteriormente, tenemos varias armas que podemos nosotros utilizar. Tenemos aquí que se puede hacer una prueba cutánea para carboplatino y aquí tenemos el control negativo y aquí es el control positivo. El carboplatino induce una reacción de eritema e inflamación en la piel, característicos de una reacción positiva. Tenemos también que, adelantándonos un poquito más, nosotros en los últimos 5 o 6 años hemos utilizado el test de activación de basófilos para diagnosticar las alergias a platinos y esto se aplica también a niños como en adultos. Vemos la expresión del marcador de activación, el CD203, que es positivo en los pacientes alérgicos y negativo en pacientes que toleran el carboplatino y en control. Es decir, que tenemos un arma in vivo en la prueba cutánea y un arma in vitro para ese diagnóstico. Y tenemos por fin que estos pacientes, niños, se pueden desensibilizar con un protocolo de desensibilización que ya, digamos, nosotros hemos establecido de 1, 2, 3 o 4 bolsas para completar la desensibilización de estos niños. Y aquí tenemos que esta niña fue desensibilizada, presentó durante la última parte del protocolo una urticaria, un angioedema palpebral, se le trató con antihistamínicos, un poco de metilprednisolona y se agitó, tuvo un poco de taquicardia, pero se consiguió que la niña tolerara el carboplatino y ha seguido en tratamiento y ha conseguido acabar el tratamiento de carboplatino. Tenemos aquí otro también que en un niño precisamente de México, que también una niña que también presentó una reacción anafiláctica por un problema diferente, que era un glioblastoma. La niña fue capaz, después de presentar una anafilaxia, de tener una prueba cutánea positiva y de ser desensibilizada. Es decir, que nos encontramos ahora con que se ha ampliado el conocimiento de lo que son las reacciones a drogas en los niños y con ese conocimiento se ha podido tratar. Vemos también que las reacciones a medicación se han ampliado, no simplemente con múltiples exposiciones tenemos reacciones de tipo IgE, pero también tenemos reacciones que son capaces de ser, digamos, mediadas por un receptor nuevo que se llama MRGPRX2 y este receptor es capaz de inducir reacciones con vancomicina, con ciprofloxacina y con otras medicaciones por mecanismos que no son IgE. Y estas reacciones también ocurren por excipientes que activarían el mastocito, como decimos, por receptores que no son IgE. Entonces, cuando nosotros hablamos de las reacciones a drogas, tenemos que pensar, como decimos, en el fenotipo. Son inmediatas, son tardías. Tenemos que pensar qué es lo que está detrás de esas reacciones y que tenemos que pensar qué biomarcadores tenemos. Hay reacciones, por ejemplo, a carbamazepina, que son mediadas por una genética HLA. Hay otras reacciones en las cuales son tardías, pues tenemos un patch testing. Hay reacciones, como dijimos, de tipo 1, en las cuales la triptasa puede estar elevada y es un marcador de activación de mastocitos. Y tenemos las pruebas cutáneas, la IgE específica y la activación de basófilos. Es decir, que tenemos una cantidad de elementos para hacer estos diagnósticos. Y como decimos, el fenotipo, observar lo que ha pasado, entender el endotipo y, sobre todo, conocer los biomarcadores. Tenemos aquí que, por ejemplo, en reacciones monoclonales pueden haber reacciones que sean totalmente reacciones infusionales, y en ese caso no se necesitaría más que premedicación, pero tenemos que los monoclonales, si son que tienen una parte murina o son totalmente humanizados, son capaces de producir reacciones de hipersensibilidad importante, en las cuales, si es una reacción infusional, no tenemos que, digamos, hacer más que una premedicación, pero si son reacciones de tipo 1 o reacciones de citoquinas o mixtas, así como si son reacciones de tipo 4, como hemos dicho antes, podemos nosotros identificarlas y podemos actuar. Por otra parte, quiero añadir de forma un poco más rápida y ampliándola, existe un nuevo, digamos, trazo genético que se conoce, que se llama hereditaria, la alfa-triptesemia hereditaria, que la triptasa, los genes de triptasa se localizan en el cromosoma 16, y hay pacientes que tienen, como si dijéramos, una replicación de una parte del cromosoma en el cual hay más genes para la alfa-triptasa. Esto se produce en familias, tenemos aquí la primera generación, la segunda generación, tercera, se produce en familias, y estos pacientes que tienen esta replicación, que es muy frecuente y seguramente en su población y en la población mundial es del 4 al 6%, son pacientes que tienen una tendencia a anafilaxia severa. Es decir, que en niños y adolescentes que tengan anafilaxias severas por medicación o por otros triggers, tenemos que saber si existe una duplicación de este gen. Por otro lado, tenemos que saber que si tenemos pacientes que tienen enfermedades de activación mastocitaria, por ejemplo, la infección por COVID nos ha dado que estos pacientes no han tenido un outcome peor, y en esta publicación que nosotros hicimos teníamos niños con mastocitosis cutánea y niños que tenían síndromes de activación mastocitario, y sabemos ahora que los mastocitos no tienen el receptor AC2, es decir, que pacientes con activación de mastocitos y mastocitosis no presentan un COVID severo. Vamos a hablar un poco de lo que es el impacto de un etiquetado de alergia a penicilina. Nosotros sabemos que cuando un niño o un adolescente se le etiqueta de alergia a la penicilina, tiene que usarse para tratar sus infecciones, ya sea sinusitis, bronquitis, otitis. Se tienen que tratar con un antibiótico de amplio espectro. La hospitalización, si es necesaria, será más larga, y se necesitará más tiempo para llevar un antibiótico adecuado, y podemos crear unas resistencias. Entonces, lo que nosotros, digamos, tenemos que tener como mandato es cierto que el paciente tiene una alergia a la penicilina, sí o no, y cada paciente es único, en lo cual hay una personalización. El sistema inmunitario es el que reacciona con los antibióticos y con las otras medicaciones o drogas, y esta interacción también es mediada por la genética, es decir, que de los niños expuestos a penicilina, una muy pequeña cantidad de estos niños van a ser alérgicos, y que la cross-reactividad entre penicilina y cefalosporinas es baja. Como decíamos anteriormente, ¿cuál es el endotipo de lo que ha pasado? Tenemos una reacción tipo 1, en el cual mastocitos y basófilos se han activado. Tenemos una anemia hemolítica, que es un tipo 2, o tenemos una enfermedad del suero, que eso ha ocurrido con cefaclor y con otras cefalosporinas en niños. O tenemos una reacción severa, como puede ser un Steven Johnson, lo cual nos prohíbe que el niño pueda haber tratado. Entonces, nuestro mandato es que cuando nosotros etiquetamos a un niño con una alergia a penicilina, lo obligamos a que de adulto continúe teniendo ese etiquetado. Y lo que nosotros sabemos ahora es que ese etiquetado no ayuda a los pacientes, porque no pueden recibir en la primera línea, porque necesitan antibióticos más complejos, con más efectos secundarios, más caros, y porque crean más resistencia. Entonces, de la población general que tenemos nosotros, ¿cuándo se produce el etiquetado? Se produce en la infancia. Y entonces nosotros, cada vez que un niño tenga una reacción que creamos asociada con un antibiótico, con una medicina, tenemos que hacer de inmediatamente una evaluación para posible delabeling. Y aquí tenemos que, por ejemplo, y esto es una cosa bien reciente, que pacientes que hayan tenido reacciones con síntomas que realmente pueden ser una náusea, una diarrea, se les puede dar una dosis de penicilina o amoxicilina y demostrar que estos pacientes no son alérgicos. Y eso se puede hacer de una forma sistemática, haciendo lo que se llama estableciendo un riesgo. Aquí tenemos pacientes, en cambio, que han tenido una urticaria en los cuales se necesita esa prueba cutánea y se necesita que el alergólogo asista para que pueda ser capaz de decir sí o no es alérgico. Y aquí tenemos los pacientes muy alérgicos que han presentado anafilaxia, en los cuales podrá haber una desensibilización, pero también los pacientes en los cuales hay que tener un etiquetado de que nunca más pueden ser tratados con esa medicina. Entonces, nosotros tenemos que ser capaces de llevar a cabo esta clasificación de riesgo. La historia alérgica muchas veces es fácil, nada más tenemos que saber qué medicación, qué indicaciones, cómo fue. Y aquí tenemos que también, basada en esta medicación, de esta evaluación de riesgo, nosotros podemos, cuando un paciente, un niño, un adolescente entra en un hospital, podemos decidir si es un riesgo muy pequeño o si es un riesgo mediano o si es un riesgo alto. Y basado en nosotros podemos decidir cómo tratar al paciente. Entonces, como decía anteriormente, nosotros tenemos que tener claramente entender cuáles son los mecanismos de las reacciones, saber de qué disponemos para hacer estos diagnósticos y saber que el mandato que tenemos los pediatras, los médicos de urgencias, los médicos generalistas, es de quitar más que de poner el etiquetado de la alergia, pero ponerlo muy específicamente en casos definidos y que tenemos disponible a nuestra disposición unas técnicas como la desensibilización, como he presentado antes, en las cuales niños con quimioterapia, niños con reacciones a monoclonales son capaces de recibir lo que se llama primera línea. Tenemos ahora un problema grave, cuál es la vacunación para el SARS, el CoV-2, para el COVID-19, en el cual se ha presentado ya claramente que hay reacciones anafilácticas que no son muy frecuentes, pero que son más frecuentes que en las vacunas normales. Tenemos, por otro lado, que estas vacunas, por ejemplo, las de RNA, contienen polietilenglicol, contienen polisorbato y que muchas de ellas, o casi todas las que utilizamos, tienen un componente en el cual los pacientes podrían reaccionar. Pero también tenemos que estas vacunas dan reacciones locales. Entonces, ¿cuáles son nuestra aproximación? Vemos aquí que, por ejemplo, pacientes que han tenido reacciones locales en la primera dosis, en la segunda dosis no tienen recurrencia y eso se consigue dando premedicación. Es decir, que una reacción local grande no es una contraindicación para la siguiente dosis. Entonces, lo que se sabe ahora de la hipersensibilidad a las vacunas en general y sobre todo a las de RNA es que la anafilaxia es rara, pero existe y es más frecuente que las otras vacunas, que las mujeres y las niñas y las adolescentes están más afectadas, que si se trata con epinefrina no hay ningún problema, que si podemos obtener la triptasa veremos claramente cuál es el endotipo de estas reacciones y que la prueba cutánea con polietilenglicol y polisorbato no parece añadir demasiado a la seguridad de estas vacunas. No tenemos ahora contraindicaciones para vacunación porque incluso los pacientes con reacciones de activación mastocitaria y mastocitosis son capaces de recibir estas vacunas y las reacciones locales no parecen recurrir. Nosotros hemos hecho, uno de los doctores aquí en Boston que tuvo la primera reacción a la vacuna de Moderna con una premedicación de cetiricina, famotidina y montelukast, hemos sido capaces, y la primera vez que tuvo la vacuna, era muy alérgico al pescado, tuvo una reacción anafiláctica que requirió 2 epinefrinas y el paciente no necesitó estar hospitalizado, volvió a casa después de 6 horas de observación. Después de 4 meses, el paciente en el cual vimos que la IgG contra la proteína Spike había bajado, le hicimos esta premedicación y fue capaz de tolerar la vacuna. Es decir, que tenemos los medios para que todo el mundo que haya tenido una reacción a vacuna pueda ser vacunado. Las guías de la FDA y el CDC americano dicen que en los pacientes con reacciones a vacunas y reacciones a componentes de las vacunas deben estar vigilados. Pero como decimos aquí, esto no es cierto, que no deben darse la segunda vacuna porque nosotros hemos sido capaces de darlo con una pauta de sensibilización y que hay que observar a los pacientes de hasta 30 minutos y el único tratamiento es la epinefrina. Entonces hay un estudio que nosotros participamos para saber, y esto hemos vacunado 650 pacientes en los cuales hay adolescentes y en los cuales hemos visto que la incidencia son pacientes con alto riesgo, son pacientes que tienen alergias alimenticias, alergias a medicación, alergias a enfermedades de asma grave y mastocitosis o síndromes de activación mastocitario. Estos pacientes han sido capaces de ser vacunados, con lo cual nosotros claramente decimos que no hay contraindicación para la vacunación. Y aquí tenemos el sitio. Entonces yo querría agradecerles, decirles que los niños que son alérgicos a medicamentos necesitan ayuda, necesitan que nosotros les hagamos un buen diagnóstico, necesitan que sepamos qué es lo que ha pasado. Una triptasa es importante en las reacciones anafilácticas, pero también necesitan saber si ha habido un blistering, si la piel ha tenido un Steven Johnson. Necesitamos saber qué es lo que ha pasado y tener un etiquetado apropiado, un etiquetado que nos dice que si el niño puede o no puede recibir una penicilina, una amoxicilina, una quimioterapia o un monoclonal. A medida que avanzamos en el tratamiento de las enfermedades y encontramos cada día más medicamentos, más dianas, vamos a tener niños y adolescentes que van a estar más expuestos a medicinas. Es decir, que la alergia a las drogas en niños, anteriormente, cuando yo empecé mi especialidad, era mayormente a antibióticos. Era la penicilina o la amoxicilina o las cefalosporinas en pacientes con fibrosis quísticas, espina bífida. Esos eran los mayores problemas que teníamos. Ahora tenemos problemas mayores. Tenemos niños que se exponen a monoclonales, niños que se exponen a quimioterapia, y esos niños se pueden sensibilizar, y aún no tenemos realmente datos claros de cuántos niños se sensibilizan, pero lo que sí tenemos es que la frecuencia está aumentando, como les digo, y que tenemos que saber qué hacer, cómo diagnosticarles, cómo protegerles y cómo tratarles. Es decir, un niño que necesita una quimioterapia es un niño que nos va a necesitar a los alergólogos, a los inmunólogos, a los pediatras. Necesita que sepamos decirle a los padres, esto puede hacerse o no puede hacerse. Se trata de una reacción grave, se trata de una reacción anafiláctica, ¿de qué se trata? Entonces lo dejaría aquí y estaría encantada de contestar a sus preguntas. Muchísimas gracias.
Excelente. Quiero felicitarlos, hemos tenido muy buena audiencia, llevamos más de 340 participantes. Les recuerdo que está el icono de interpretación, ahorita estuvo en español, pero la siguiente sesión será en portugués. La doctora Josefina Rodríguez Cernadas nos habla sobre los patrones de sensibilización en quimioterapia, y quiero dar un agradecimiento importante porque la doctora está saliendo ahorita de COVID-19, está bien, estuvo estable, pero habíamos perdido comunicación con ella, y la verdad es que se puso las pilas y nos dijo, no se preocupen, yo ya había quedado con ustedes, y nos hizo la grabación. Entonces, la verdad, un aplauso y un agradecimiento hasta Brasil. Ella es especialista con más de 10 años de experiencia. Su campo de acción es la hipersensibilidad a fármacos y de sensibilización a AINES, también antibióticos, y tiene más de 82 publicaciones que hablan sobre hipersensibilidad a medicamentos. Los dejo con ella y muchas gracias por su asistencia.
Okay, so first of all, I would like to thank the scientific committee of this drug hypersensitivity summit for the invitation to be here talking about subject that is I'm very honored to speak about. First of all, I have to say that in relation to this presentation, I don't have any conflict of interest. So today we are going to talk about desensitization in children, especially desensitization concerning drugs used in chemotherapy in children. First of all, I want to say that I'm a senior allergist and immunologist specialist and senior lecturer in the Central University Hospital of São João Porto in Portugal. And we are going to speak about desensitization. First of all, with some slides to understand the concept of drug desensitization. After, I'm going to talk about chemotherapy and desensitization. And finally, I'm going to talk about our own center experience and conclusion related to desensitization in children, because also we work with desensitization in adults, but nowadays we are talking mainly about desensitization in children, because our center is very specialized in this kind of procedures in this kind of age. So the drug desensitization, generally we say that it began with the discovery of penicillin in 1928 by Alexander Fleming, as everybody knows. And why this happened and this began by that time? Because it was discovered by this year and it was commercialized in 1941, and even nowadays is the most popular and most prescribed antibiotic around the world. And it really soon after the beginning of the utilization of the penicillin, the reactions, hypersensitivity reactions, and some reactions with the very severe grade of reactions began to appear. And so why was it necessary to begin to think how to solve the problem of reactions, allergic reactions to drugs that were so necessary to treat some kind of diseases? And in that time it was syphilis and tuberculosis and other infectious diseases. Nowadays we also have other antibiotics that can substitute penicillin, but by that time we didn't have any other antibiotics, and so the first procedures of desensitization really began with penicillins. So for everybody to understand what is drug desensitization, there are some generic principles that I would like to share with you. So with the drug desensitization, we induce incremental doses administration of a drug over hours or days to abrogate immediate and delayed hypersensitivity reactions. When can we do this? In reactions that are IgE mediated, in reactions that are not non-IgE mediated but are have immediate features and the clinical manifestations are as such as an IgE mediated reactions, and in some types of delayed hypersensitivity reactions. And it is very important to know and to interiorize that desensitization is a temporary process. It lasts as long as the drug is in circulation. If the drug is interrupted, subsequent administration of the drug must be also by the procedure of desensitization, and the re-desensitization is required if doses are missed. And we know now that drug desensitization can be performed in patients of any age. So the first recommendation when a patient reacts to a drug, it is to avoid the culprit drug, as well as those with cross-reactivity, to prevent drug-induced reactions in future uses. Or use a drug, a non-related drug, must be or can be prescribed as a safe alternative. And the majority of cases can be managed safely by this approach, to avoid the culprit or to use a non-related molecular drug like the culprit that induced the reaction. Desensitization is only necessary when the previous reaction is well documented and not severe, and it's preferred. It's always important to know the mechanism behind the reactions that the patient had. So desensitization procedure is a risky procedure, and we must always measure the individual risk-benefit evaluation of the situation. There are many desensitization protocols, and nowadays we can almost say that we can desensitize any kind of drug. We cannot desensitize for any type of, for all the reactions, as we will see later. But nowadays we can try to desensitize almost any reactions for any drugs. Of course, that the most frequent desensitizations drugs are for biological and monoclonal therapy, and nowadays for chemotherapy. But other drugs can be also desensitized. The first step to decide if we are going to perform a desensitization procedure, it is to be aware of the severity of the reactions. And we have in this table the 5 grades of the immediate reactions, and immediate reactions that we know are induced by IgE mechanisms. So if we take in account the five grades of Messner and Ring, we can desensitize the patients with the immediate reactions, even if the patient had an anaphylactic reaction. The indications for immediate reactions are as I said, anaphylactic reactions, patients that have angioedema, patients that have urticaria, patients that have a maculopapular rash, that these reactions are induced between 1 hour and 6 hours after the drug is or intake or made by IV perfusion, and there are some delayed reactions that occur after this time of 6 hours that can be also, we can also try to desensitize to these drugs. It is we are talking about the fixed erythema, even if it's a simple erythema or if it is multiple erythema, and also in maculopapular exanthemes that have late appearing when the patient is taking a drug. These fixed eruptions, we have some experience with this kind of manifestations, and we have some patients with reactions to allopurinol that we have managed to desensitize also. The absolute contraindications for drug desensitizations are the STRIF, the AGEP, the acute generalized exanthema pustulosis, the multiform erythema, the toxepidermal necrolysis, and drug reactions with eosinophilia and systemic syndrome symptoms that is called the DRESS syndrome. For our children, we can desensitize when? As I said before, desensitization can be performed in patients of any age. Hypersensitivity reactions may occur in children during the use of chemotherapy agents, can be a problem that can induce the interruption of the treatment, and the outcome can be fatal. The immediate reactions are the most common type of hypersensitivity reactions in children that are submitted to chemotherapy. Rapid drug desensitization allows these patients to be treated with first-line agent prolonging their survival and even with remission of total remission of the basal disease. And the decision to proceed with desensitization is based on a strong suspicion of hypersensitivity reactions and in the absence of an equally effective alternative drug. The most popular protocol for desensitizing in chemotherapy in adults and in infants and in children is the protocol that is been proposed for many years by Mariana Castells, where we use classically three solution bags, and as you can see in solution concentration, each bag has a tenfold increase in the solution comparing to the previous one. So we have a solution A, B, C with a tenfold increase in the concentration of the drug in each bag. And then we administer each bag for the time that is proposed in the protocol until we achieve the total cumulative dose that is proposed for the treatment for the patient and for the kind of the drug that we are dealing with. So here is a slide that really only shows another form of the one that I showed you before. And about our experience with desensitizing children, we have been desensitizing children with a diagnosis of low-grade glioma and with immediate reactions. The median age and the index reaction was 3 years old, ranging from 18 months till 9 years old of age, and half were boys. A minimum number of 8 cycles of carboplatin, that is one of the major drugs used in the scheme of therapy, were administered until the infusion the infusion rate was started. Usually pre-medication like steroids and antihistamines combined with slow administration of drug was tried by oncologists in mild cases before they asked the opinion and the orientation of allergologists. Reactions were from moderate to severe. 9 immediate reactions were anaphylactic. of grades 2 and 3 of Ring and Messner classification, as I showed you in the slide, in the previous slide. No statistical differences between the severity of the index reactions, sex, age, previous exposure, or surgeries, but with the number of cycles was found. Only with the number of cycles was found a statistical difference. So we had in this series 14 patients with immediate reactions, because we are going to see late reactions too. We performed 90 treatments with 6 of them we had to make a slight modification, as I'm going to show you later. 8 patients, we had to put them in a more complete adaptation of the protocol, reinforcement of pre-medication, and to put in the protocol 1 or more intermediate steps. Only 2 patients had unsuccessful desensitization. They were put in alternative drug with a bad outcome, let's say like that. So in our data, we saw that 86% of success for this kind of treatment with desensitization with the carboplatin. Sorry. So in the beginning of our work, many years ago, we began with the Cofino-Cohen in 2011 protocol, and only later we adapted and we began to use in a formal way the protocol from Mariana Castells. That is, like I said, classically with a 3-bag solution and 12 to 14 steps of administration of the drug. Here we see the data from the 14 patients and the numbers of cycles and desensitizations that we have performed on this kind of patients. We also see the type of the reactions that each one of the patients had. And you can see that sometimes some patients, even with desensitization procedure, have had some kind of related adverse events. Most of these events were mild in severity, were more slight than the reaction that was induced when the reaction occurred. The 3 protocols that I have here, the first one is the classical one with 12 steps and 3-bag solutions. As I said, with a 10-fold increase in concentration from bag A to bag C. The second figure, we had to introduce intermediate step because the patient reacted in the 9th step, and so we had to to introduce intermediate step. And in other patients with more severe reactions, we had done this, and we can do it in other patients and in other pathologies and in other ages also. We have introduced another bag of a smaller concentration even, because the patient can react, and many times react in some of the steps. And in this kind of patients with more severe reactions during the procedure of desensitization, we used to introduce another bag with 4 bags with also a 10-fold increase in concentration, but with the first bag with a slower concentration than the other ones. So the desensitization was successfully performed in the majority of patients, even in infants. A survival of several years was achieved after this approach. Delayed type of hypersensitivity reaction classically constitutes a contraindication of desensitization, but in selected cases of uncomplicated exanthemas, or when the culprit drug is irreplaceable, this option might be considered and tried. No delays in treatment schedule occur due this type of procedures to drug desensitization or drug-induced intolerance. And to our knowledge, this is the biggest case series for now on desensitization to chemotherapy in children, with an overall of 98 procedures performed with a success rate of 86% for carboplatin. This slide is a little bit complicated, but it's only to say that, as you saw, the majority of our experience is in solid tumors, in gliomas, because our center in the hospital, San Juan Hospital, it's dedicated to solid tumors. Also, we have some experience in liquid tumors that comes from the another hospital in front of ours, dedicated only to treat cancers and in children and in adults. And we received 4 patients to treat. 3 of them were treated with desensitization concerning methotrexate that was used for the treatment of acute lymphoblastic leukemia or lymphoma. One of the patients with immediate reactions had 9 years old, and 2 other patients, one had 8 years old and the other 9 years old. And the importance for me to talk about these 3 cases is that the desensitization procedure and for the treatment of these patients, they need to have methotrexate by IV perfusion, but also in the end, they need the administration of a small dose of intrathecal methotrexate. And it was very important in the first case that is in this slide, the 9-year-old male, 9-year-old boy, because we had not any experience in the desensitizing intrathecal methotrexate. And so we had a conversation with Mariana Castells that said and told us that it was better after desensitizing the patient by IV perfusion, we should also make an approach, a very, very timid approach to the intrathecal administration of the drug. So in this first patient, we had the administration of 1 per ml concentration of the drug, then 1 per 100, and then 1 per 10, and after the remaining dose necessary for the treatment of this patient. And this went very well. Nothing occurred, not even in the desensitization with methotrexate by IV route, nor by intrathecal route. So we thought that when we were called to treat, to help to solve the problems of patients 2 and 3, some years after, we thought that maybe if we could desensitize these patients by IV route with success, maybe it was not necessary to take so much care with the intrathecal administration of the drug, because this administration was made at the end of the IV perfusion of the methotrexate, and maybe it went all okay. So we made this approach to these two children, and we didn't take any sort of other care with the intrathecal administration of methotrexate, and everything went well. The last case, the patient 4, is a patient with 12 years old of age with an acute lymphoblastic leukemia, and it was a patient that had a non-immediate reaction to the treatment with methotrexate. It was non-immediate reactions that were expressed with a macular papular rash. The photograph is not very visible, but it was a huge boy of 12 years old, and he had an erythema that was present in all the thorax and abdomen, also in the legs and the feet. And first of all, we treated the exanthema, and we proposed to desensitize the patient using a modified protocol with a longer time of perfusion of the drug, because first of all, because the total dose was very high, and because the reactions was a non-immediate one, and our experience says that for these cases we must have much more time to perform the protocol. So we did this, and everything went well from our part, from our point of view, but unfortunately, for other reasons, there was no remission of the disease, and this boy finished to die with the very sadness of us. So to summarize the general approach of desensitization procedure, I must say that as a general principle, to decide when, where, and how to proceed, we can follow this algorithm that is very simple, as you can see in this slide. In practical issues, we must be aware that this procedure must be done by specialized allergists with skills in this field, in specialized hospital centers, many times, and mostly concerning children. This procedure should be done in intensive care units, and it is a very risky procedure. Tolerance is temporary, and either on immediate and non-immediate reactions. So I showed you the desensitization to carboplatin in low-grade gliomas, and it is already published, this data, only for carboplatin, and also I showed you some desensitization protocols concerning also treatment of non-solid cancers like liquid tumors as leukemia, lymphoblastic leukemia, and lymphomas, and treatment with methotrexate in immediate and non-immediate reactions. In non-immediate reactions, we must be aware that we can only proceed with desensitization when the reaction is not severe, as I showed you. So that is all, and I thank you all for your attention and for your patience with my English that because of COVID, this COVID time is not, we have not been in many conferences, so it's very bad, my English for now. So thank you all for listening to me.
Muchísimas gracias por su participación, doctora, y esperamos que se recupere pronto, se acabe de recuperar del COVID, y agradecemos el esfuerzo por haber podido participar con nosotros. ¿Hay por ahí alguna pregunta que le mandaremos más adelante? Y la siguiente conferencia es nuestro profesor, es el doctor, si me pasan la primera, Bernard Yu Hortong. Él es especialista en alergia, inmunología y reumatología de adultos. Él es presidente del Comité de Alergias a Medicamentos y miembro del Grupo de Trabajo de COVID-19 de la Asociación de Alergia, Asma e Inmunología Clínica de la región Asia-Pacífica. Es presidente de la División Médica y profesor adjunto en la Facultad de Medicina Lee Kong Chian en Singapur y consultor para el Departamento de Reumatología, Alergia e Inmunología del Hospital Tan Tock Seng en Singapur también. Él nos va a hablar de pruebas de provocación a medicamentos en niños. Y con esta es nuestra última conferencia del día de hoy. Les recuerdo que hoy, mañana y pasado tenemos este curso y que todas las pláticas son pregrabadas. Les agradecemos mucho que las preguntas nos las hagan llegar por escrito para que las podamos hacer llegar también a nuestros profesores en esta última actividad académica de Compedia. Muchas gracias.
Thank you for inviting me to speak at today's Drug Allergy Summit. And my topic today will be on drug provocation tests in children. These are the drug provocation test guidelines which are currently available in the literature. And they include the Joint Task Force Practice Parameters from the American Academy of Allergy, Asthma, and Clinical Immunology from 2010. The European Academy ENDA guidelines published in Allergy in 2003. The International Consensus of Drug Allergy published in Allergy in 2014. And the risk and safety requirements for diagnostic and therapeutic procedures in allergology published by the World Allergy Organization in 2016. The drug provocation test is a diagnostic test which involves the gradual dose escalation up to the maximum target dose, total target dose, or course of a medication to which the patient is suspected to be hypersensitive or allergic to. In children, the most commonly tested drugs include the non-steroidal anti-inflammatory drugs called the NSAIDs and the beta-lactam antibiotics. Do note that a drug provocation test is not the same as desensitization, which is a therapeutic modality which involves rendering temporary tolerance to a drug to which the patient is hypersensitive or allergic to. And in the desensitization literature in children, the most commonly desensitized drugs include antibiotics, chemotherapeutic agents, and monoclonal antibodies. So what are the indications for a drug provocation test? The drug provocation test is the gold standard diagnostic test for drug allergy and hypersensitivity. However, it is not carried out in all individuals, and it involves a very careful, individualized risk-benefit evaluation where the benefits of the drug provocation test do need to outweigh the risks. So a drug provocation test should be avoided for drugs of limited future necessity. These are the four main indications for the drug provocation test. To exclude hypersensitivity, where the history is non-suggestive or symptoms are non-specific, So this could involve doing a drug provocation test in the form of a single-blind or even a double-blind placebo-controlled drug challenge. The second indication would be to provide safe pharmacologically and/or structurally non-related drugs in proven hypersensitivity. So for example, an alternative beta-lactam antibiotic. The third indication would be to exclude cross-reactivity of related drugs in proven hypersensitivity. Again, for instance, the use of cephalosporins in a penicillin allergic individual. And lastly, the definitive diagnosis where the history is suggestive, but where there are negative, non-conclusive, or non-available allergological tests. There are also specific contraindications to drug provocation tests. For example, in pregnant women, where the comorbidity, where the drug provocation test may provoke a situation beyond medical control. For example, in an acute infection, uncontrolled asthma, or an underlying cardiac, hepatic, or renal disease which is unstable. Immunobolus drug eruptions, a severe systemic initial reaction are also contraindications to drug provocation testing. However, there may be exceptions to these so-called contraindications where the benefits may outweigh the risk in certain situations. So for example, suspected local anesthetic hypersensitivity in a pregnant woman who is scheduled for an epidural anesthesia, or in antituberculous drug allergy in the treatment of active PTB or pulmonary tuberculosis, where it's imperative to reinitiate treatment at some point in time. And lastly, carbapenem use in suspected beta-lactam allergy and an extended spectrum beta-lactamase or ESBL positive bacteremia. In these situations, there may be an urgent or fairly emergent need to have a drug provocation test done in order to elucidate and in order to give the patient an appropriate antibiotic to use or an appropriate drug to use. So these are the situations where a drug provocation test is either not recommended or contraindicated, where the index reaction was a generalized bullous fixed drug eruption, an acute generalized exanthematous pustulosis or AGEP, in severe cutaneous adverse reactions, for example, Stevens-Johnson syndrome, toxic epidermal necrolysis, or DRESS syndrome, where the initial reaction was severe, for example, a systemic vasculitis, or a specific organ manifestation, for example, a hematological thrombocytopenia, severe leukopenia, or hemolytic anemia, drug-induced hepatitis, tubular interstitial nephritis, and pneumonitis. And if the index reaction was severe anaphylaxis, then a drug provocation test is also not recommended. Certain types of drug-induced autoimmune diseases are also contraindications. For example, drug-induced lupus, pemphigus vulgaris, or other types of immunobolus eruptions. There is quite a bit of literature on childhood beta-lactam allergy, and this is an IACI task force report which talks about beta-lactam allergy in children and the types of diagnostic procedures which could be offered. So in this position paper, it is stated that skin tests could be skipped before a drug provocation test in children with benign non-immediate reactions to beta-lactams. However, what's unresolved in this position paper is the optimal allergy workup to perform in children with so-called benign immediate reactions and how the management of children with severe cutaneous adverse drug reactions should be undertaken. So in drug provocation testing in children, there are sufficient literature to talk about short versus extended provocation tests. So for example, a study on non-immediate beta-lactam reactions has demonstrated that a one-day provocation test followed by an observational period of at least the time interval of the index reaction could be safe. Because if this challenge is negative, an extended home provocation could subsequently be carried out over a 3 to 7 day period. And this study showed that there was no difference in the negative predictive value. For a short drug provocation test, the negative predictive value was up to about 97.5%, and an extended drug provocation test, the negative predictive value was 93.8%. And following a negative drug provocation test, however, it was noted that beta-lactams were still refused by carers in up to about 14.75% of the children requiring subsequent treatment, and 6.98% in the short drug provocation test group versus 18.9% in the extended provocation test group refused subsequent use of the antibiotic, even though it was tested negative. The negative predictive value of a 5-day prolonged DPT is also fairly high at up to about 99% in another study of 355 children with a median age of 4.2 years when the drug provocation test was carried out. However, there remain issues regarding extended provocation tests. Whether new sensitizations occur as you provocate over a prolonged period of beyond 3 to 5 days, or whether even desensitization occurs through re-challenging the patient or the child with the drug. So direct oral provocation tests can be offered where there is a low risk, immediate and non-immediate index reaction, where drug provocation testing can be carried out without prior skin or blood tests. Most of the literature in the pediatric literature pertain to amoxicillin, beta-lactam as a representative of beta-lactam antibiotic allergy. And there are also some series which describe their experience in certain centers with NSAIDs and other non-beta-lactam antibiotics like the macrolides. So as a rule of thumb, the dose increment would be starting at 10% of the target dose at 0 minutes, and then at 90% of the target dose at either 20, 30, or 60-minute intervals later, up to a daily therapeutic dose. And using oral provocation tests in these fairly low-risk children, the outcomes were 1 to 2% mild immediate reactions and 4 to 6% of mild delayed reactions in the studies that were published as referenced at the bottom of this chart. However, there is a possibility of new sensitizations occurring with extended drug provocation testing. And in the paper published by Kusakolchai V. et al. In the World Allergy Journal 2021, a case of amoxicillin dress which occurred on day 4 with the child presenting with fever, maculopapular exanthum, atypical lymphocytes, and elevated liver enzymes was described. So delabeling antibiotic allergy is something which has been fairly well described in the literature in the last 2 years, especially in pediatric allergy. Bear in mind, however, that most times oral direct challenges should only be reserved for low-risk individuals. So for high-risk patients or where the index reaction was severe, there would still be a need to consider using either in vitro tests, for example, the serum-specific IgE levels or basophil activation tests for immediate reactions, or cellular tests for delayed reactions, or using skin tests, both skin prick and intradermal testing, and even consideration of delayed intradermal testing with patch tests for the delayed T-cell mediated reactions. So in any risk-benefit assessment of delabeling or even in considering a direct oral provocation test, one needs to risk stratify the patient's index reaction. So a low-risk reaction would include a rash, itching with rash, abdominal pain, vomiting on its own, an asymptomatic individual but just with a family history of drug allergy, non-specific symptoms like dizziness, headache, cough, nausea, runny nose alone, or diarrhea alone, these would constitute what we would call fairly low-risk clinical symptoms and signs. In contrast to the high-risk reactions, where high-risk clinical manifestations, for example, in Stevens-Johnson syndrome, TN, and DRESS syndrome would include a history of peeling of the skin, oral cavity or body blisters, or a fairly severe delayed reaction. And in the immediate reactors, a high-risk anaphylaxis index reaction could present with symptoms and signs including facial swelling, difficulty breathing, lip swelling, wheezing, throat swelling, or a documented objective drop in the blood pressure. So bear in mind that the risk-benefit assessment is based principally on the history of the index reaction. So how would we go through preparing the patient, and in this case, a child in particular, for a drug provocation test? So the most important thing to consider would be the time interval between the index reaction and the day of carrying out the drug provocation test. Ideally, it should not be earlier than 4 weeks following the acute episode. There should be at least 5 times the elimination half-life of the drug which has passed, and the initial reaction should have resolved both clinically and in terms of a laboratory test, all laboratory tests should have normalized. Informed consent should be obtained from the parent or the legally accepted representative, explaining the indications for the drug provocation test, the benefits, the risks, and the alternatives, if any. And in high-risk individuals, always consider skin testing, in vitro testing before drug provocation test. And in low-risk individuals, low-risk children, we could proceed directly to an oral direct challenge. The route for which the drug provocation test is going to be carried out must also be carefully considered. Generally, we would try to use an oral route if possible, unless only non-oral formulations are available for the index reaction or the suspected drug. So in terms of preparing the drug and the formulation of the drug, bear in mind, oral syrups and capsules are usually preferred. Syrups for children in particular, because they are a bit more palatable, it would be easier to feed a child a syrup. So syrup, amoxicillin, cloxacillin, augmentin, cefalexin, paracetamol are generally available. If the syrup is not available in the formulary, then one needs to consider using a capsule, which involves perhaps even opening the capsule, or using the tablet by crushing the tablet, the unit dose, and dissolving it in 100 ml of normal saline, for instance. But do bear in mind that certain types of tablets are not crushable. For instance, an enteric-coated tablet, for example, ciprofloxacin, would not be recommended to be crushed. If oral formulations are not available, or if the index reaction was an IV and you want to see whether the child is able to tolerate a parenteral formulation again or not, IV preparations could include, for example, diluting the parent drug in 100 ml of normal saline, starting at the first 10 ml and then escalating the dose gradually every 30 to 60 minutes. For example, 10 ml, 20 ml, 30 ml, and then the final 40 ml. So how do we prepare the child and the parent for the drug provocation day itself? So generally, we would recommend a light breakfast. Morning medication may be taken or omitted as instructed by the attending allergist. Very important that at least 3 days before the drug provocation test, the child's parent or legally accepted representative should be contacted to ensure that the child is in good health. And without any signs of a recent allergy or a viral infection. On the test day itself, generally what we would recommend would be to measure the parameters for the child. For example, the blood pressure, the pulse rate. Peak flow meter reading might be useful or might be important, for example, in asthmatics or where there was bronchospasm anticipated because that may have been described in the index reaction. And so these parameters should be monitored before the start of the drug provocation test and ideally following each provocation dose. If the index reaction was suggestive of a severe systemic reaction or anaphylaxis, one could consider putting in an intravenous cannula, in particular in the older individuals, the teenagers, for instance. And in terms of the dosage of test preparations and test intervals, in general, most drug provocation tests would start at 1 in 100 or 1 in 10th of the therapeutic dose, with the time interval between doses at least 30 minutes or so. And the target dose to attain would be either a maximum single therapeutic dose or a total daily dose. The time for completion could be either within hours, days, or weeks. Bear in mind that there is a lot of conflicting literature regarding the target dose and the time to completion of the dose, and the practices do vary in different parts of the world, even in adult allergy. So during the course of the drug provocation test, observations should be carried out with the nurse or the pharmacist leading. Very important that the doctor or an allergist must be in attendance in the event of a reaction occurring. So if a mild reaction occurs, then the child should be observed for at least 2 hours after stabilization. And with adequate emergency treatment, the child could be discharged with antihistamines or oral glucocorticoids on standby. But if the reaction was severe, hospitalization should be mandated, at least for a 24-hour observation period, in particular for biphasic reactions or a delayed reaction occurring. And this is the same as the practice that we do in adult allergy, as well as for the observations for the teenagers as well. Adverse events do have to be carefully documented. There are various scoring systems which have been reported in the literature and which may be done in various centers. But again, many of these are not validated. What's very important would be a photo documentation of the skin manifestations, as this could be useful for future reference. And all corrective measures, resuscitation measures must be properly documented. In the event that it was a successful negative drug provocation test and there was no immediate reaction, a phone follow-up the next day would be recommended, both for immediate as well as non-immediate reactions. And ideally, there should be some documentation of subsequent tolerance of a cause of the drug to which the drug provocation test was negative. Usually because of logistic reasons and resource constraints, it's not very feasible to follow up every drug provocation test, every negative drug provocation test, to see whether the child, the parent, or the legally accepted representative finally or ultimately gave the child the drug or not, because the situation may not have arisen for the child to receive the drug. So what about the interpretation of drug provocation test results? Bear in mind that false positive reactions can occur. For example, psychological symptoms, pre-existing symptoms, for example, urticarial flares, a drug-induced aggravation of pre-existing disease, for example, psoriasis in adults, or even self-infliction of positive symptoms or signs. Most of these do tend to happen in possibly the older children and sometimes in adults as well. What about false negative results? False negative results may occur if there is a missing cofactor. For example, light co-medication and acute viral infection or physical exercise, which may have been present during the index reaction. If the exposure and or the observation time was too short, you could also get a false negative result. If the time interval from the index reaction was too short or too long, this may also result in a false negative result. And if the dosage was too low, for instance, a single dose versus a daily therapeutic eliciting dose, this could also result in false negativity. And last but not least, the process of desensitization occurring and tolerance induction occurring through drug provocation testing may also result in a false negative. So at the end of the evaluation, I think it is extremely crucial that an allergy passport be issued to the patient or the parent. This should include documentation of the generic and the brand name of the drug and the active ingredient of the index reaction, the date and type of the index reaction, and the severity, whether it was just cutaneous or whether there was systemic or organ manifestations as well. The method that was used for evaluation, the history and the plausibility, whether it was definite, probable, or plausible just based on the history alone, the types of in vivo tests that were done and the results, the types of in vitro tests, if any, and the results, and finally, the drug provocation test, the maximum tolerated dose that was attained. And where possible or where necessary, recommended safe alternatives could also be written down. And last but not least, the most important step, which is delabeling on the electronic medical record, in particular for negative drug provocation tests. So in conclusion, in drug provocation tests in children, very similar to adults, the risk-benefit assessment has to be clearly assessed and documented. So for example, if it is a child with recurrent infections who requires different types of antibiotics, for which different antibiotics have been labeled as developing drug allergy or hypersensitivity reactions, or a child, for example, with inflammatory arthritis, with frequent dysmenorrhea, where there were suspected NSAID reactions, or where an alternative like a selective cyclooxygenase 2 inhibitor may be required. In these situations, definitely the benefits would far outweigh the risks of testing the child regardless of the age. Of course, in certain situations, if the drug is not needed urgently, then we could consider doing the drug provocation test at a later date, for example, when the child is older. In particular, for NSAID-sensitive individuals where selective COX-2 inhibitors are considered as off-label in the very young children and are only registered for use in the older children. Secondly, a direct oral provocation test can be considered in low-risk index reactions, and there could always be a short versus extended course drug provocation test, which could be considered in certain situations, bearing in mind that the longer the course of the drug provocation test would impact on adherence, in particular in trying to get young children to take the medications regularly over a 3 to 5 day period. And of course, the unnecessary induction of antibiotic resistance when the antibiotic is not needed. And last but not least, drug provocation tests are also very useful in delabeling inaccurate antibiotic allergies. But having said that, probably something more important would be the avoidance of inappropriate use of antibiotics and NSAIDs in the first place. Thank you very much for your attention.
Muchas gracias por su asistencia. Tuvimos muy buena asistencia este día. Estuvimos casi en los 400 participantes. Les recuerdo que tenemos, el curso está avalado tanto por el Consejo Mexicano de Certificación en Pediatría con 8 puntos, como por el Consejo Nacional de Inmunología Clínica y Alergia, 12 puntos. Qué bueno que aprovechen. La verdad es que todas las sesiones estuvieron, las pláticas estuvieron de muy alto nivel académico. Les agradezco su asistencia y nos vemos mañana y el jueves en este Summit de 3 días. Muchas gracias a todos y buenas noches. Que estén muy bien.